And welcome back to Open Med School. Last time we have said about the major cardiac symptoms. The cardinal symptoms of heart disease are, as we know, one is the chest pain, second is breathlessness, third palpitation, syncope or pre-syncope, and edema. Edema can both be a symptom or a sign. Today our discussion is on chest pain. The chest pain of decreased blood flow to the heart of varying etiology. The most common cause is atherosclerosis. So here we can see a normal blood vessel. The endothelium is smooth. As age advances, you can see here deposition of fatty material and the formation of plaque, and this will lead on to a fixed obstruction. The problem with the fixed obstruction is that at rest the lumen is sufficient to allow blood to pass through, but at times of stress or when the heart rate is high, oxygen supply or oxygen demand increases, and due to the obstruction, blood flow to heart is insufficient. This leads on to production of substance P, adenosine, lactate, etc. in the cardiac muscle that stimulates the cardiac autonomic nerves, the sensory nerves, and impulses reach the spinal cord, and from there it is referred to the dermatomes C2 to T10. That is why the pain of ischemic origin is perceived. Now we think about what are the types of this anginal pain. Anginal pain can be classified into one, the stable angina or otherwise called effort angina. Second is the unstable angina. Third is the Prince-Mettels angina. Prince-Mettels. And there is another type, the microvascular disease producing angina. So today we'll be discussing about these three major types of angina. So any cardiac symptom we discuss on the OPQRSTA. OPQRSTA. O stands for the onset and duration of the symptom. The anginal pain, when there is a fixed obstruction, it occurs on exertion, and usually it lasts 5 to 7 minutes and is relieved on rest. As it is occurring on effort, this angina is called effort angina, and most of the features are stable. That is the duration of the pain, the exercise needed to induce the pain, the intensity of the pain, all are fixed, and that is why this type of angina is called stable angina. Then think about where is the position of the pain. The pain is usually described as the central region. It's called a retrosternal or a substernal pain. The cardiac pain is a visceral pain. All the visceral pains are illocalized, in contrast to somatic pain, which is strictly localized. So the cardiac pain is a diffuse pain. The patient will show the hand like this, and this sign is called the Levin sign. As you can see, the patient is keeping the fist on the chest. Is called the Levin sign. And what is the Q stands for the quality of the symptom? It is usually described as burning, bursting, oppression, heaviness. It varies from person to person and place to place. The description will be varied. And usually it's felt as a heaviness. Some people say as if an elephant is sitting on the chest. That will be the expression. Then comes the aggravating, relieving, and the radiation. We are mainly concerned with the radiation. The cardiac pain refers to inner aspect of the left arm, inner aspect of the right arm, to the neck, to the epigastrium. I already mentioned C2 to T10. Sometimes the central pain, that is the retrosternal pain, may be absent. The pain may be only felt on the areas of reference. For example, somebody walking uphill and developing a pain over the lower jaw is very characteristic of an anginal pain. Another example is an epigastric discomfort on walking. Again, that is suggestive of highly suggestive of anginal pain. So remember, the central chest pain can be missing. Then comes the severity. Usually the pain is tolerable in stable angina, in unstable angina, and when the patient develops a myocardial infarction, pain will be very severe, and they get an impending feeling of death. That is, so can be so severe. The temporal progression and the duration we have already mentioned. Usually the pain, stable angina, it is usually 5 to 7 minutes. The pain. More than 5 minutes or 5 to 10 minutes, 7 minutes, and less than 20 minutes, it is we call as unstable angina, about which we will discuss. More than 30 minutes, it is suggestive of a complete occlusion of the blood vessel, otherwise called myocardial infarction. Associated features like you can get sweating, palpitation, breathlessness, giddiness, etc. along with the pain. But these are not common in stable angina. With the development of unstable angina or myocardial infarction, you can get these symptoms. So we have covered what is the stable angina. Now we move on to what is called unstable angina. Unstable angina composes somebody with a stable angina. There is a plaque is there. There is a complication. The plaque occurs. The plaque ruptures and thrombus occurs. That is called a non-occluding thrombus. Non-occluding means the thrombus doesn't completely occlude the blood vessel. Some blood flow is possible, and the thrombus is lysed by the intrinsic thrombolytic systems also. So thrombus is formed, thrombus is lysed. And the significance of this is that this is a more severe case. So the patient may go into myocardial infarction or arrhythmias and death can occur. So the treatment here, it is non-occluding thrombus. So the treatment is anticoagulation. So that is the importance of, and other management of unstable angina will be discussed in detail later. So the pathology in unstable angina is a plaque rupture, formation of a non-occluding thrombus, a dynamic process. Then if the thrombus completely occludes, it becomes myocardial infarction. In myocardial infarction also, the features are same, only thing the intensity and duration of the pain is much greater than that of a angina pectoris. And unstable angina includes what we have said, the stable angina patient developing unstable. Unstable means the duration of pain increases, intensity of pain increases, the exertion required to produce the pain also decreases. So a stable has become unstable. This type of angina, you can call it as a crescendo angina. Crescendo. And next type of unstable angina is somebody developing a rest pain. Anybody developing a rest pain, we don't know when will be the next pain. So it is again an unstable condition. Third is the first time pain, first episode. Even if it is on exertion, the first episode of anginal pain for the first 2 months, you call it as can consider it as unstable angina. These are the major varieties of unstable. We have said about the crescendo angina, the resting pain developed, and third is the first episode of angina. And some people, after the myocardial infarction, again, suppose pain is occurring, again some people consider as an unstable state. Then we go to the third type of anginal pain. It is called Prince-Metals angina. This is an important term. You remember Prince-Metals angina. So it is otherwise called vasospastic angina. So here you can see the blood vessel has gone into a spasm. It can occur at an area where there was a plaque, or it can occur in areas where there are no plaques. So the mechanism is spasm of a major vessel. An epicardial vessel goes into spasm. So what is the clinical relevance? In angina, what usually you get is ST segment depression and T inversion. So in case of unstable Prince-Metals angina, rather than you get ST elevation. So ST elevation is a characteristic feature of acute myocardial infarction. So Prince-Metals angina can be confused as myocardial infarction unless you take the history properly and see what is the duration of the pain. That is one point. So repeat ECG shows ST segment suddenly coming down or becoming normalized without any treatment. It is suggestive of a Prince-Metals. Second is due to vasospasm. So drugs like beta blockers, which can produce sometimes coronary spasm, should not be used in Prince-Metals angina. The calcium channel blockage should be the drug of choice. So these are the two important clinical points to remember. So we have mentioned the three types of angina: stable angina or effort angina, the unstable angina, Prince-Metals angina. Then comes the microvascular angina. In microvascular angina, what is happening? If you do a coronary angiogram, the blood vessels are normal. The small vessels are affected. Another thing you should remember is what is called the second wind angina. Second wind angina means a patient on exertion develops chest pain. Without taking rest, the pain subsides again to recur later. So this is called the second wind angina. Now we look into what are the common causes for the angina. The first and foremost is coronary artery disease due to atherosclerosis. We have already shown the picture. So CAD due to atherosclerosis. Second, conditions like aortic stenosis, where the work of the myocardium goes into hypertrophy, the blood vessels may be compressed, requirement of oxygen demand and substrate use increases. It can lead on to again ischemia. Third is aortic regurgitation. So this one, two valvular conditions you should remember when somebody gets anginal pain: aortic stenosis and aortic regurgitation. Of course, include the hypertrophy cardiomyopathy that can also lead on to. Then coronary arteritis. Conditions like vasculitis can lead on to coronary arteritis, and that can lead on to. So these are the common causes that you should consider. Then rarely other conditions are there. Just remember atherosclerosis, valvular disease like aortic stenosis, aortic regurgitation, then vasculitic conditions can lead on to anginal pain. You can classify the angina, especially the effort angina, according to NYHA grading, which we have discussed, or Canadian Heart Association grading. Canadian Heart Association grading. They grade it into 4 grades: 1, 2, 3 and 4. 4 means patient is having pain even at rest. So they have got pain, significant limitation. So that is the grade 1 angina at rest. Second is grade 3 means angina on walking level grounds or climbing a flight of ordinary state. that is level ground bar 1 flight of stairs. Grade 2 means walking uphill. Level grounds you have got no angina, but on walking uphill you can get, or climbing more than 2 flights of stairs. Grade 1 means no angina on ordinary activity, but on strenuous exercise you may get pain. So only on strenuous. So this is the Canadian Heart Association grading for angina. In the next session we will be coming with the management of angina and what are the investigations to be done for angina. Hope this session was useful to you. Stay tuned. Thank you.